It's all in your head. You don't look sick. Your tests are normal. It's probably anxiety. There's nothing wrong with you. Have you heard these words from physicians, family, and friends? If you're someone who has been struggling and swirling through the revolving door of healthcare to find answers about your health, or if you know someone who is going through this experience, then this podcast is for you. Welcome to the Desperate for a Diagnosis podcast with Laura Nozica, a show dedicated to exploring the challenges of living with undiagnosed or rare medical conditions. This podcast explores both sides of the bedside. We will be speaking with patients who have had challenges with finding a diagnosis, along with experts in the field. I'm your host, Laura Nozica. Please note I am not a medical professional, nor am I affiliated with any healthcare, pharmaceutical, or device company. I am an entrepreneur, and I am an independent market researcher focused on helping healthcare organizations better understand the patient perspective. The podcast is not meant to offer medical advice, but to merely share the stories and perspectives of podcast guests. Hello, and welcome to the Desperate for a Diagnosis podcast. I'm your host, Laura Nozica, and I am here today. Oh my gosh, I am in the presence of medicine royalty, is the way I would say it. I am honored to be with the esteemed Dr. Alan Rapoport, and he is going to walk us through all things headaches and migraines and talk you through some of the just amazing things that he has done and researched and studied and presented during quite the career of medicine. And we will dive into all of that in just a minute here, but I'd like to introduce everyone to Dr. Rapoport and go through his bio, and then we will dive into a subject that I think is interesting to a lot of people out there who suffer so terribly from migraines and other types of headaches, which we will be talking about. And he will walk us through some ways that patients can get relief. So here we go. Dr. Alan Rapoport is a clinical professor of neurology at the David Geffen School of Medicine at UCLA, Los Angeles, California, where he teaches medical students, neurology residents, and fellows. He is a past president of the International Headache Society and the founder and director emeritus of the New England Center for Headache in Stamford, Connecticut. Board certified in neurology and headache medicine and a fellow of the AHS and the AAN. He has co-authored more than 350 articles, chapters, and posters on headaches and other neurological diseases. He has lectured around the country and internationally, which I know this because Dr. Rapoport, you gave me kind of the rundown of your schedule coming up. So he is a world traveler for sure, but he has presented to general physicians and headache specialists and has appeared many times on national radio and television programs such as Today, CBS This Morning, and Good Morning America. So again, I'm in the company of royalty and a TV star. Who knew? I had no idea. He has been the editor of Headache, CNS Drugs, and editor-in-chief of Neurology Reviews. He reviews for many peer-reviewed journals such as Cephalalgia, Neurology, and New England Journal of Medicine and Headache. He has co-authored 9 books on headache for patients, physicians, and nurses with Drs. Fred Sheftel and Stuart Pepper. He's on the go all the time. He has no dull and boring moments. He is the co-founder and CEO of Bone Triage, a medical IT company in Silicon Valley, California, dedicated to helping patients and doctors around the globe by collecting detailed patient histories online using AI and shortest pathway analysis technology and linking them with a new app, which we will talk about, Migraine Mentor, which monitors patient progress and outcomes. And it doesn't stop there, not just with migraine, but he's also, in addition to headache, moving into Alzheimer's disease, sleep, depression, anxiety, chronic pain, and other areas. He has served on all kinds of boards as well for the American Headache Society and is the immediate past president of the Fairfield County Neurological Society in Connecticut, the founding president of the Headache Cooperative in New England, the founding director of the Headache Cooperative of the Pacific. He has been the director of the Headache Day at the annual International Controversies in Neurology for 15 years. So, again, Dr. Rapoport, it's nice to have you with me today. And like I said, you have all these dull and boring moments, clearly.
Right. Well, I did start out as a general neurologist in Stamford and Greenwich, Connecticut for about 7 years. But during that period of time and covering 3 hospital emergency rooms and teaching at Yale, I got interested in headache and pain. And from there, I started concentrating some more of my time, although I actually still see a little bit of general neurology just to keep my hand in it. But
Uh-huh.
I really became a headache specialist and writing on headache and seeing mostly headache patients over the last 30 years or more.
Wow, wow. Such a fantastic career, and certainly in an area where there's so much need with something that's so debilitating for so many people. And I'd like to kick off our conversation, doctor, just to talk more about the different kinds of headaches, because there might be a lot of confusion around what's the difference between that regular old tension headache versus migraine versus cluster headache. We hear a lot about different headaches, but it would be great if you can walk us through I'm sure there's more than 3 different kinds, but these some of the main ones that might be more familiar to listeners.
Well, depending on who you read, there's a minimum of 151 kinds of headache. So did you say we had 5 hours for this podcast?
Whatever you need, doctor, whatever you need. We'll do a
But
series.
I will, I will talk about the 3 that you mentioned. And by the way, one of the reasons I'm very fascinated about your podcast and wanted to talk with your audience is because your title is The Desperate Need for a Diagnosis. And would you believe that it used to be just 50% of people that get to a doctor that knows how to make a diagnosis had a diagnosis. 50% didn't have a diagnosis for over 3 years and they were trying to get one. Now it may be as little as 40%. It may have come down to 40%, but it's a real problem because, and we'll talk about this later, I think doctors really don't get enough training in medical school, and the general physician that sees most headache patients first before they get to specialists, they have so many things that they have to learn from every organ system that they really don't have the time to learn properly about how to make a diagnosis. So let's talk first about migraine,
Okay.
which isn't the most common. Tension type is the most common, but it's the most common severe headache that we have. And migraine is an occasional attack of severe pain, which is usually on one side of the head, but it could be on both sides. It's usually throbbing in nature and very severe and associated with nausea, sometimes vomiting, tremendous light sensitivity, sound sensitivity. So people want to hibernate. They want to go into a room without any light, without any sound, and throw up in private.
Yep, yep.
And that's
I
if
have
they
I have
don't,
been there. I've been there.
and that's if they don't have good treatment. And that is anyone without a diagnosis, obviously, and sometimes even people with a diagnosis. Now, migraine typically occurs, let's say, 2 to 3 times a month.
Mm.
It can last 4 hours to 72 hours, which is 3 days, although it usually lasts a day, at least till you go to bed that night and wake up in the morning, and even a full 24 hours. It uh, occurs in families because it is inherited in some way, that even though there's been hundreds and hundreds of articles on the genetics of migraine. We only know 3 types, which are quite rare, where we absolutely understand the genetics. We have an idea about the genetics, but all we really know is if a woman has migraine and she has kids, there's a chance that the kids will have migraine and a bigger chance in the girls than the boys, because in fact, there are 3 times as many women with migraine as men. So when you sit in my waiting room, and most of the people I will see will be migraine, 75, 80% of the people in my waiting room are women. Men do get migraine, and there'll be some men with migraine there, but it's way more in women. And some people will have that 2 to 3 times a month, but it could last for a day or two. Some will have one attack a year. Some will have a few attacks in a lifetime, but typically it's 2 to 3 a month. And it could be many times a week. And there are a smaller percentage of people with migraine who have what we call chronic migraine, which basically means they have attacks more than 15 days a month and sometimes every single day. And the people with chronic migraine, which is, let's say 10 to 15% of all people with migraine, are more likely to have other illnesses along with it, especially depression, anxiety, other chronic pain conditions. They're likely to have a little more trouble responding to medication, and they're very likely to have a diagnosis, which I wasn't really going to talk about, but I need to mention it, called, we don't have a good name for this, but right now it's officially called medication overuse headache.
Oh,
Because if you have pain 15 days a month or more, you want to relieve that pain. If you take most of the acute care medicines, which are medicines that you take to knock out a pain right now, some of them not specifically for migraine, like an Advil or an Excedrin or an aspirin or a Tylenol, and some of them specifically for migraine, approved for migraine. Most of those medicines, if you take them more than 2 days in a week, you will actually probably start having more headaches.
oh, that's interesting.
And if I give you the right medicine, it may not work that well, because this does something to the brain to prevent the normal medicines from working. It's a very complex topic. Now, we could take it up again a little bit later, because I know a lot about it, because I've been studying it for 30 years.
Sure.
But many people don't know about it. So if your viewers and your listeners take any combination of different medicines more than 2 days a week, they may actually be making things worse for themselves.
Oh.
So they should get to a doctor and say, I've got to take the right medicine in the right way. So, getting back to migraine, uh, if somebody gets to a headache specialist or a neurologist that knows a lot about migraine, or even a general physician or nurse that knows a lot about migraine, then if you have 1 or 2 attacks a month, they will prescribe for you a medicine. It could be an older one, or one of the newer ones, which have some advantages. And you would then probably be able to get rid of that pain within an hour or two, or at least it will start going away, and it should be gone within 4 hours. And if it isn't, then you need a different medicine, or to go to a different doctor or nurse.
Doctor, that's what I was going to say.
Right, maybe.
Yeah. Yeah.
Which is pretty remarkable, because when I started out in medicine, we had one medicine for migraine. It didn't work very well, and most people had their attack for 24 to 48 hours. And now we're talking about 2 hours, or at the worst, 4 hours. So
Wow.
that's pretty incredible.
Yep.
The other way to treat migraine is not just acutely with a medicine, and I should also mention some devices in a minute, but some people need prevention, which means taking a medicine on a regular basis to decrease the number of migraine attacks. Now, it must sound intuitive that everybody should take a preventive, but if you only have 2 or 3 attacks a month, and whatever medicine I give you for the acute care of that migraine works really well without side effects, you don't need a preventive. But we are now saying if you have 4 or more migraine attacks a month, averaging once a week, we would probably want to treat you with a preventive medicine. And some of them you take once a day, some of them you take once a month, some of them you can actually take once every 3 months. And they work to decrease the number of headaches you're having, and maybe also decrease the intensity of the pain, decrease the length of the pain, and some of those side effects like nausea and light sensitivity and so on.
Mhm.
So we have medicines which treat acutely and preventively. There are also behavioral medicine techniques. There's a lot of other ways to treat migraine, but I should mention if you learn to relax, if you learn biofeedback training, if you do yoga, there's a lot of things you can do to make yourself better without taking medicine. There are also vitamins, minerals, and herbs. And there are devices. Now, most doctors don't deal with the devices because up until very recently, the devices are not covered by insurance companies, and they can be pretty expensive. But there's one device, which happens to be the one that I like the most, which actually came in at a reasonable cost for most people, not everybody, like about $80 a month. But some people would say that's too much for them. But now they have insurance coverage from about 3 big insurances, kind of in the middle of the country, not yet on the East or West Coast, but they're working on it. And that's called Nerivio, Nerivio. And it's very simple, but it would take a while to explain how it works and how to use it. But basically, you put it on the upper arm. It looks like a blood pressure cuff. And you turn it on for 45 minutes, and it sends a stimulation up the arm to the spinal cord in the neck and up to very deep areas in the brain. And it turns on the body's own ability to get rid of pain.
Oh,
When
interesting.
I,
Is
when I
is
first,
that only indicated for migraine, doctor, or other
At this
conditions?
point, it's only indicated for migraine, but that's a very good question because they will be, I think they've already started testing fibromyalgia and maybe
Yeah.
tension type headache and so on. But right now,
Yeah.
it's approved for migraine, and you do need a prescription from a doctor,
I see.
but your doctor can find out how to get this Nerivio for you. And it's made by a company called Theranica, Theranica. And any doctor's office can find out about it and prescribe it. And there's no serious side effects. The only side effects might be a little warmth here or tingling or something. You have to learn how to use it, but I learned how to use it, so it's pretty easy. And
Yeah.
it's controlled by your smartphone, actually.
What isn't
And
controlled by our smartphones these days, right?
exactly. Except your wife or your husband usually
Well,
isn't
that's true.
with a smartphone.
Well,
Yeah,
that's probably coming too, and we're going to talk about AI. So that's probably Not that far down the road, right?
Right, right. So, and there are 4 other devices in the US that are approved that are pretty good. Some of them are a little expensive, but they all kind of work. Rivio works, I think, a little bit better, but you have to try a couple of different ones. But this one's an easy one to use. They have wonderful data. I mean, when we look at data from a study, from a medication that we're going to give to a patient, we look at how many people are pain-free at 2 hours
Mm,
versus the placebo, because all of this has to be double-blind studies to get approved by the FDA, and how many headaches you have over a period of time, and does that shorten? Because this Nerivio can be used acutely, just like a medicine to knock out migraine now, but it could be used every other day as a preventive also. So we're getting into the realm of you don't necessarily need a medicine. You
yeah.
can have something less expensive that actually has very few side effects.
Sure. And
So that's
so many people prefer not to take something pharmacological for anything really, if they can avoid.
certainly after they've had some side effects,
Yeah.
or maybe at the very beginning. Do I need a medicine? I hear these medicines cause a lot of side effects. One other thing I just want to mention about migraine before we move on to tension type headache. Um, Migraine has different phases, and a lot of people have heard about the visual aura that can occur with migraine. And only about a third of people with migraine have the visual aura, and it occurs within an hour before the pain starts of migraine. So, right at the beginning, either just before or at the beginning of an attack, 93% of the time it's visual, and people see all kinds of things, zigzag line, blinking on and off, growing in size, in rare cases, blocking one half of your field of vision. Sometimes it's just blurred vision, but we don't consider that an actual aura, but a lot of people do get blurred vision and blind spots and flashes of light. There are a lot of things that happen. Usually doesn't go on for more than 25 or 30 minutes. And then you have the pain from the migraine. So people like it because they know they've got to get their medicine ready, but they dislike it because it means they're probably going to get a migraine attack. But I should mention that people over the age of 50 can have an aura without pain, even without having had migraine in their lives. And it's pretty common. And it happens to many of your listeners, and they get a little worried about it the first or second time, and they go to the eye doc
Oh,
because they
mhm.
think there's something wrong with their eyes,
Sure.
usually their brain, but
Ah,
they don't realize it. And it's not usually serious. But the very first time it happens, you don't know what it is. And so you
yeah.
probably should get checked out. And the last thing I'm going to tell you about the migraine process, even before the aura, and it can go back a day before the migraine attack occurs, people have what's called the prodrome. Something happens to them, and it happens to them every time, often before their attack, which warns them that they're going to get a migraine. So they might have a little tiny headache, very mild, or a neck pain, or some discomfort in their neck, or they may have a little depression or anxiety, or they may start eating things, or they may yawn a lot, or start running to the bathroom a lot. And after a while, if you mention it to them and say, do you have these kind of symptoms beforehand? And they say, no one's ever asked me that, but I do get that. Once they can identify this and they know that a headache's going to follow, there's a medicine that they can take during that prodrome that might block the headache from coming.
Interesting.
So migraine is really fascinating. There are a lot of aspects to it. what I've just told you is probably more than the average doctor knows about migraine. But that's why if you're not getting good, care, you should try to get to see a headache center or a headache specialist. And the problem is there are 50 million people in America with migraine
Mm.
and 800 headache specialists.
Wow, definitely not
Eh,
enough to go around, or those wait lists seem
No,
very long.
no. That's why you need some special techniques. So let's talk about
Yeah,
tension type headache.
yeah.
It's the most, yeah,
Doctor, if I could, before we move on to that, I have a couple of
sure,
questions for you.
sure.
You mentioned that in your waiting room, 75% of the folks waiting to see you are women. What do you attribute that prevalence to?
That's a good question. Some people think men cause headaches or women that they spend time with. That has not been
There's
proven.
I'm sure that's on the list somewhere for
It
cause
hasn't been proven.
or a
It's
trigger.
it's probably hormonal, but then you might ask, well, why do men have migraine? Because they don't have the same hormones. They actually have some hormones too, but um, but women have fluctuating hormone levels every month when they're in childbearing ages. So age 11 or 12 up to 40 or 50. So that's a long time in your life. And they get menstrual periods, menstrual cycles. And during that time, what happens is the estrogen levels rise. And then right after the bleeding starts, the estrogen levels fall. And it's been shown, but maybe not proven, that the falling levels of beta estradiol trigger a migraine attack. Not 100%, but that's what we think happens. There are other hormones as well that you have to look at, and everybody has their own theories, but I've always practiced saying it's much, it's not the rising level, it's the falling level of beta estradiol. And I've always practiced, I give back a little bit of estrogen in a patch during that period of time, sometimes with patients, and that tends to help it.
Oh,
Or you can just give the medicines that you know work, and that tends to help it. Or you can give a non-steroidal anti-inflammatory, and that may help it. Um, but we think it's mostly hormonal and probably genetic. People say, where did my migraine come from? I kind of jokingly say, your mother,
blame the
because
mother.
it does come from your parents and more from the mother's side than the father's side. And you can't change your parents, it's one of those things. So you have to just deal with it. One day, there are a lot of breakthroughs in medicine these last 10 years, and the latest breakthroughs are genetic manipulation. And one day, they'll find exactly what it is. And even after you're born, they may be able to change something genetically in people. Or if the mother has migraine, they might be able to do it in utero, but that's already a little bit dangerous. And, do you really want to do that? But right now, we can't help it if you're born with migraine. We just have to treat it.
Yep, got it. Yep. Um, so covering a little bit more, doctor, if you could, about tension headache versus cluster headache, and then I'd like to talk more about diagnosis and some of those things as well. So
Okay.
walk us through a little
So
more
let
about tension and cluster headaches.
okay, let's take tension headache. We actually call it tension hyphen type headache because we don't have a good name for it yet. It used to be called tension headache. And so everybody thought that meant they were tense or that they had tension in the neck muscles. Both things can cause it, or neither can cause it. So we call it tension type headache. It's coming from someplace in the brain. We now know that it's a little more similar to migraine than we used to think, but very mild compared to migraine. So actually, a tension type headache doesn't have those characteristics that migraine has. It doesn't get to severe most of the time. It's usually mild to moderate in intensity. It doesn't last 4 to 72 hours. It can be an hour. It can be all week. It's not on one side of the head most of the time. It's on both sides.
Okay.
It doesn't pound and throb most of the time. Nausea might be a little bit if it's severe, but there's rarely vomiting. Light and sound sensitivity doesn't usually occur. So we teach other doctors that it's kind of the opposite of migraine. All the things that you diagnose migraines with, you don't have intention type headache. And it's very common. Um, I rarely know people that have never had a headache. And if they say they get one once in a while and they describe it, it sounds like a tension type headache. Of course, some people drink too much alcohol and get a headache. That's a little different, but it's also not a migraine, although migraine patients know that alcohol is bad for them. So
Yeah.
they rarely drink wine, champagne, even stronger alcohols. Uh, they know. And sometimes they say, well, I feel like drinking tonight. I know it's going to happen. I have my medicines and I'll
They're ready.
suffer
Yeah.
silently.
They're
Um,
ready.
and so if you look at the literature, some studies say it only occurs in 25% of the population. Some say 85%. I would say it's probably closer to 80 to 90% of the population that occasionally has a tension type headache. And it can be pretty bad. And rarely, very rarely, I'd say less than 10% of those people can have chronic tension type headache, which means it's there all the time or very frequently, but it's not as bad as migraine. And we know how, or we think we know how to treat that too. Um, so that's tension type headache, but it's really quite common. And the last thing I'll say about it is if you have migraine and tension type headache, and most people have both, so they'll tell me 3 times a month they'll have a pretty severe headache with all the things that come with migraine. And once a week or twice a week, they might have a milder headache on both sides or in their forehead or in their eyes and in their temples, but it's both sides. And they say they take an aspirin or a Tylenol or a nonsteroidal anti-inflammatory, or they loosen their tie, or they go for some exercise, or they get away from their boss.
Right.
And all of those things can be helpful for it.
Yeah.
And it could be a very mild migraine, and we need more information about that, and that's being studied. So the FDA, when you put a patient into a migraine study, the FDA said it can't be a very mild migraine. It has to be moderately severe or severe because they want to make sure we're studying somebody with migraine, not tension type headache. And the milder migraines look like tension type headache.
Yeah. Yeah. One thing I'm curious about, doctor, is that when I've had my headaches and oh boy, when it causes things like nausea and it triggers vomiting and even diarrhea. I don't know. After I throw up, I feel so much better. Why? Why is that? And why does migraine trigger those types of really unpleasant symptoms?
I'll answer the second question first because I know the answer to that. Migraine affects areas deep in the brain, and some of them have to do with what we call the autonomic nervous system, which controls the peristalsis, your intestinal contractions, your stomach, nausea, vomiting, your blood pressure, all kinds of things. And migraine slows down the GI tract. So if you have nausea, what it means is food, instead of going down into your stomach and into your intestine, it's coming up
I see.
because it can't go down because it's slowing the intestinal transit time. And this is very important when it comes to treatment, because if I give you a pill and you're the kind of person that has severe nausea and sometimes vomiting, guess what? If you don't throw it up, it still won't get down to the small intestine where it gets absorbed into the body to go to the brain or wherever it's going to start working. So some people will tell me that medicine you gave me, terrible, it doesn't work. I say, well, it's the best medicine I have. But I say to them, maybe it's not getting down to be absorbed. We may need to bypass your GI tract by giving you either an injection or a nasal spray.
Right.
And in the old days, we used to sometimes give a rectal suppository, but in this country, people aren't comfortable with that. In some countries in Europe, they prefer that because they know that it's going to be very well absorbed, but it doesn't go over well here. So we've had them, but we don't really use them that much. But I will tell you, since I'm not the first doctor to see my patients, because I'm hard to get into, so I'm usually the seventh doctor to see a patient, and they're sent by other neurologists or headache specialists. And they tell me, I've been on a triptan. I've been on 3 different ones, and I can talk about triptans more if you want to. But that was what came 25 years ago and revolutionized the treatment for getting rid of the headache now. And we have 7 of them. But I only ask them one question. Was it a tablet? Because all of them are made with tablets, but some of them have injections and nasal sprays. And invariably they say, yeah, it was a tablet. And I
Yeah.
say to them, it's not that the triptan doesn't work. It's that it never got down to the area
I
where it got
see.
absorbed.
Wow.
And,
Wow.
and I'm going to give you a choice of one of 2 things that will really work, but it's not as easy as taking a pill. And you've got to decide if you want to do that. So that's
Yeah.
interesting. And
That
I'm
is,
glad you asked that question.
yeah. Yeah. That's interesting that either the mechanism of action or the mechanism of administration can make a difference on whether or not these meds work for patients.
Administration is we call it route of administration and mechanism of action are 2 of the most important things when you're designing a new medicine for migraine. And I'm in the process of helping a company do that right now. And we're talking exactly about, is it by mouth? Is it by nasal spray? Is it by injection? That's the route of administration. And will it get through into the GI tract, down into the GI tract? Most people don't know this, but medicines are not usually absorbed in your stomach. I mean, you take it in your mouth, it goes down through the esophagus to your stomach, but then it has to go through some valves into your small intestine. And then, of course, it goes into the large intestine and then out. But it's in the first part of the small intestine called the jejunum or jejunum, where most of our pills get absorbed. And if it doesn't get there, it doesn't work.
Interesting.
So,
Wow.
so now your listeners know more about why medicines don't work for their migraine than anybody.
Yeah, that's fantastic to know because then
I ought to write a book about this.
I know you got to add to that list of 9 or
I've
10.
written 10 books about this. I'm not writing another one. My last book is really good, but unfortunately it's old, but it has information like this in it. And it's called, I have to remember what it is. It's been so long. Conquering Headache.
Oh, okay.
Very thin, soft covered. I'm sure you can get it in a second hand, go to one of those secondhand sites and look it up. And if you think it's phenomenal, you might convince me to write one more book, but it
Well, but
takes
that's
a long time.
It does. Books do take a long time, but thank goodness that you hung in there and were willing to get that information out to patients and I'm sure doctors as well. But how wonderful to understand how medicines work because then I would think that that would just empower patients that much more to say, okay, well, I have an idea of how medicines work. If this
It's
tablet isn't,
scary.
what else can I take that's a different type of administration?
It's scary because when your listeners now go into their doctor and say, well, I know that route of administration is important and where it gets absorbed is really important. And the doctor's going to look at them and say, oh boy, I got a tough one here,
Mhm, that's
right?
right. Right. Well,
Because doctors don't like those kinds of questions, but they empower the patient to ask the appropriate question. You're absolutely right.
yeah,
I
yeah.
like it. I like it because that gives me a chance to really explain it to them. But, they bring in stuff from the internet and they bring in a lot of AI stuff. And I look at it and I go, I said, Let me tell you the way I do it. And, I don't like to make them do what I'm suggesting. I like to give them choices, but I don't like them to make wrong choices. That's for
Yeah.
sure.
Yeah, definitely. Like they say, just because it's on the internet, it must mean it's true, right? It's
Right.
true. I
And
love
and if you see me on television, you're gonna believe everything I say because I'm on
it.
this big important show. But they haven't they've seen my background. So of course they're not gonna put a total jerk on
I,
TV,
I, I think
but
you're
they
pretty
think I know something.
I think you're pretty legit, doctor. I think that we know 100%. But yeah,
Yeah.
that's wonderful information. And this is why I do this show because I want patients to get the right information that they can take to their doctors who, as you said, you can't really you can't know everything. And that's why, as you said, patients are going to multiple physicians to get answers. And at some point, someone will have an answer, but you, as a patient, you just really have to have the wherewithal to keep moving and pushing for answers and advocating for yourself. And that's why it's so important for me to get this type of information out there.
I'll tell you one little story about migraine treatment. So about between 25 and 30, well, it was 1991. So that's over 30 years ago, I
Mm.
think. So 1991, the first of the 7 triptans came out. And it was called Sumatriptan. It's still around. A pretty good one. I have others that I like more. And the brand name was Imitrex.
Oh, sure.
And the FDA at that time wouldn't let um, advertising on TV have both the brand name and what the condition was that it was used for. In their wisdom,
Hmm.
doesn't make sense to me, but that was the story. So
Wow.
they wanted to tell people that, and it was an injection at first, only an injection.
Right.
So it was a big deal, but it was the first of these new drugs. So the company, either by accident or on purpose, did something brilliant. They named the division of that company that made this and sold this. They gave it an interesting name, like Serenex. Sounds like a drug, but it wasn't the name of a drug. It was the name of that division of the company.
Well,
So they said, here's this shot that takes migraine away in half an hour or 20 minutes.
hmm.
And they had data to prove it. And they said, brought to you by Serenex. So people started looking up. They couldn't find Serenex. So they called their doctor and they said, what's this Serenex drug that is a shot that takes your headache away? Within a week, millions of people had called their doctors
Yeah,
and the doctors knew nothing about it. They
wow.
looked it up and they said, oh, this looks good.
That's the
So
power of direct to consumer advertising in the pharmaceutical world, isn't it?
but it was tricky. It was very tricky. They couldn't
Found
do
a
the
way
two.
around it. Yep, they found a way.
Now, as you know from watching TV, you can see Lady Gaga talking with a brand name, and you know that it's for migraine,
Yep,
right?
yep.
So the FDA got a little loose. And by the way, when I travel to Europe, people are amazed when I tell them that if I watch a show, there'll be a 5 minute intermission with 6 or 8 TV commercials, most of them for drugs.
Yep.
They don't have that in Europe. They think it's wrong. They think we're crazy. And I sort of agree a little bit. It's too much. You can't get away from it, you know?
Yeah.
But anyway, let's talk about cluster headache.
Yep. Let's do it.
Cluster headache is the worst headache known to man. And I say to man because it occurs slightly more in men than women. It's the only headache that occurs more in men than women. And I know you're going to answer me why. I don't know.
Mm.
And
That's
I
an
don't think we
honest
know.
answer, doctor. That is an honest
Yeah.
answer. I respect you for that.
Yeah.
100%.
And I don't think anyone really knows yet. If they say they know, tell them to speak to me because I want to learn, but I'd be cautious. It's very different. It's usually starting around age 30 to 40, but it could be in a kid. It could be in a 70-year-old, but more often than not, the prevalence is more in middle life kind of time. It comes out of nowheres, and it's the most severe pain you can imagine, also on one side of the head, but usually in the eye, behind the eye, over the eye, or in the temple. And it could be elsewhere, but that's where it is 90% of the time. So excruciating that the patient can't stand it. And they would pluck their eye out if they could. And sometimes they describe it as though a huge pressure is pushing their eye out of the socket.
Oh,
And
goodness.
along with this horrible pain, which thank God only lasts an average of 45 to 60 minutes, and rarely as long as 3 hours, whereas migraine can last 3 days. Along with it is a very definite autonomic response. There's that word autonomic again, the automatic part of the nervous system that goes on behind the scenes. And what happens is their eye on that side only usually turns red. It starts to drip, tearing. The eyelid may close. If you look at it carefully, the pupil on that side may get smaller. They may be sweating over here. The nostril on that side may get stuffed and it may start to drip. You don't usually get all of those things, but if somebody tells me that out of nowhere, oh, I didn't mention, it's only an hour-ish, but it comes back 2 to 3 times in the day, often in the middle of the night, waking the patient up. At the same time every day, like clockwork. And it comes at the same time every year. And after 4 to 8 weeks, it disappears just the way it came.
So is that
So it's
daily?
very unusual.
It's happening daily, doctor, during a period?
Most days of the week, but usually daily when it's episodic and comes and then goes away. We have some old treatments. We have some new treatments. We have pretty good treatments for it. Incidentally, the acute treatment to stop it, there's only 2 things approved by the FDA. One is that same shot of sumatriptan that was discovered 32 years ago.
Yep.
Only that one. And breathing pure oxygen from an oxygen tank also stops it. And that's the safest thing you can do because, breathing oxygen is good for you, actually. So, but it comes 2, 3 times a day, most days of the week, 4 weeks, 8 weeks, and then it disappears and very short-lived with all these other findings. There's almost nothing else that can do that. Maybe a sinus infection could do that, but not really if you get a proper history. So the average general doctor not familiar with cluster, when they hear some of these symptoms, certainly the first time, they give an antibiotic for a sinus infection.
Oh,
And maybe a second time because it didn't go away. And then it goes away. And next year, if it comes back, it can come back 6 months, a year, 2 years, just the same curious way. When it comes back, the doctor forgot that they gave the antibiotic. They'll do it again. But when we hear this story and the patient says, well, my doctor gave me a Z-Pack, or some other antibiotic, I mean, we know what the diagnosis is if they say it keeps coming back. So that's cluster. And the pain, we measure pain on a scale of 0 to 10. Obviously, 0 is no pain. 1 is a very mild pain. Migraine usually gets to 8 to 10 out of 10. Cluster headache, we only measure it on a scale of 10. But when I say to a patient, on a scale of 1 to 10, how severe is it? Many of them say it's a 15.
yeah.
I mean, they can't even describe it. And what do? The behavior is different. They rock back and forth. They bang something into their head or their eye. They bang their head on the wall.
Oh my
And it's
goodness.
been dubbed suicide headache
Mm.
because there's a rare form of this, which is called chronic cluster headache, which happens all year round for many years. That might only be every other day, but can you imagine having this horrible thing week after week after week?
No, no,
And
and
they're
there's
very hard to treat.
yeah, and there's nothing for it other than, like you said, Imatrix and oxygen.
There,
But what does that say?
look,
If oxygen helps, what does that say about how this type of
it's
headache
it's
functions?
doing something to the brainstem cells to help it. And we're learning a lot more about it. It used to be thought to be due to blood vessel dilatation, getting too wide. Now we know it has a lot to do with a ganglion that's behind the nose called the sphenopalatine ganglion. And there's a treatment where you can actually stimulate or give medicine to that ganglion, either this way or through the mouth or the nose. And there are treatments that work on it. And actually, the best treatment is the mildest treatment. And it's giving a medicine which is used for blood pressure called verapamil.
Mhm.
It's a medicine that's in common use, and there are many other types, but verapamil itself, although it's not approved for it, that's what I start with all the time. And you have to give a higher dose than the normal dose that you give. And a big percentage of the time, it really knocks out the cluster headache. And
Mm,
steroids, which you got to be careful about.
yeah.
And they could be used for very severe migraine, but they really work well in cluster headache. And there's many other things to talk about, but those are the most common treatments that we use for typical cluster headache.
Wow.
And the last thing I've already mentioned, just to remind people, medication overuse headache, typically coming with migraine and typically coming with chronic migraine, where it occurs at least 15 days a month. If you use acute care medicines too often, depending on which kind they are, it usually makes things worse. There are some newer medicines that don't make things worse, but you're not supposed to use them quite that way.
Mm.
And that's pretty much what I think we should talk about, because that'll cover, 93% of the type of headaches that your listeners have.
Yeah.
And there are some rare ones that we haven't talked about.
Yeah. And again, doctor, in terms of diagnosing any of these types of headaches, it's mainly a clinical diagnosis or upon clinical exam, meaning that it's nothing that there's a lab test, imaging. Are you doing any imaging for these types
You're
of?
absolutely right. The diagnosis of headaches right now is totally by history. And as I've kind of told you what each headache is like, a good doctor would take a history from you and ask all the questions that to get the answer that I was suggesting. And they can make a diagnosis that way. They may not be 100% sure, but they'll be close. And they should do a neurological examination. Even if they're not a neurologist, they can do an abbreviated one. And they must look into the eye with an ophthalmoscope to see the back of the eye, because what you're really looking for is not a sign of migraine, but a sign that something else is wrong. You can tell a lot from just the eyes and the eye movement and the vision. You have to check all of that. But when you look to the back of the eye, if you see swelling and increased pressure, that means something else is going on. And it could be pressure in the central nervous system is too high. Um, it could also be too low, but you probably couldn't see that by looking in. And you would have a good idea if anything else was going on. If you were unsure, you would order either a CAT scan or an MRI scan of the brain. MRI is usually better than a
Mhm.
CAT scan. You have trouble getting them quickly, but not urgent. You just wait for the MRI scan. So you just have to do one scan and there's no X-ray involved. It's magnetic stimulation.
Yep.
And why do it? Just to rule out something much more serious like a stroke or a brain tumor or very high pressure with expanding ventricles. I sometimes try to talk my patients out of a scan because if I really think it's migraine, what I say to them is, you have migraine. I'm pretty sure from my neurologic exam, you don't have anything else wrong. If we did a scan, I'd be 98% sure rather than 95% sure. But scans are read by radiologists that have to report every single thing they see on a scan. So if they say, as they often do, we see these little white spots in the white matter, the patient's going to say, what is that? And
Mhm.
I'm going
The
to say,
incidental
I can
finding.
tell you,
Yeah.
it's probably not related, but we don't know. And then they say, should I have another scan? And I say, we don't know. But if we do another scan, there might be more of them. Or worse, we might find something that is actually a little bit wrong, but doesn't have to be corrected. And the patient's going to say, do I need another consultation? And once they say that, I say, I don't know, but if you want one, I'm glad to send you to someone, and it's going to come back that no, don't do anything about it. Even if it's a benign brain tumor, we might not do anything about it because not all tumors need or should be, you know, operated upon. So I say to the patient, we might find something that will lead to more tests. Do you really want that? And they say, I trust you. And I'd say, I'm only accurate to 96%. And then we decide together that if things aren't going well, or if my treatments aren't working, we'll do a scan just to be sure.
Sure.
If a patient insists on a scan, the doctor should do it. Because the worst thing that could happen is if something is found, but the doctor says you absolutely don't need a scan. That sets up a lawsuit,
I'm
unfortunately.
sure. I'm sure. Yeah. Or like myself, I have sinus issues that have caused really nasty headaches. Again, to rule things out, like you said, if imaging were to be done, most likely to rule out versus rule in.
Yeah, if you told me that you had all these sinus complaints, I'd say it's possibly due to your migraine, but let's do an of your, or actually, it's a CT scan of your sinuses, which gives the best information. MR scans overread sinuses. CT scans are really good, and we'll see. And if you have something really bad, then the ear, nose, and throat person may want to do something. But I have to tell you, well, I shouldn't tell you, but I have to tell the audience that in my very long career, I've sent loads of people to good ENT people. Fewer than 10 people have ever been operated on.
Mm.
And those that do get operated on sometimes don't do so well
Yeah.
afterwards.
Yeah. Yeah.
And it's tricky. It's very tricky. I don't want to take stuff away from the ENT people, but I'm very cautious about suggesting operations on a
Yeah.
sinus.
For sure. Yeah, yeah, it's, I've had friends who've had sinus surgeries. Luckily, I don't need any of that, but, once in a
Yeah.
move where the allergies get whipped up and then it whips up your sinuses and it's a big
Yeah.
spiral.
Well, treat
I've
it
had
with allergy medicine.
right,
And
right.
by the way, one thing I have to tell you, most patients who come in to see me say, and especially if it's early on, they say, I have sinus headache.
Oh, okay.
And at the end of the consultation, I say to them, you don't have sinus headache. And they say, well, why do my sinuses fill up when I have this terrible headache? I say, because the nerves where migraine occurs go to the nose, go to the
Oh,
sinuses, go to the mouth, go to the chin, and activates mucus secretion. And that's why you feel like you have sinus stuff. Now, there are some people that probably have both, but if you don't treat them for migraine, they're not going to get better.
look at that. It just goes to show you how everything is connected.
It's all connected, and most patients and a lot of doctors don't really understand this. So it's good that the patient should hear it. And I'm not saying there's no such thing as sinus headache. There was a study done by a very good bunch of headache specialists where they studied a few hundred people who said they had sinus headaches. Guess what percentage of them actually had migraine and no sinus headache? Take
Mm.
a wild guess.
Oh, I guess we maybe go high here. I don't know, maybe
93%.
that's higher than I thought. Wow. Okay.
And it doesn't mean there's no such thing as sinus headaches. It just
Yeah.
means that, when I get the history of 2 attacks a month where you're lying in bed throwing up one-sided headaches, you may
Sure.
have a sinus problem, but you have migraine
You
too.
have migraine. Yeah. Oh gosh, so such amazing information. But I want to make sure, doctor, that we get to talking about helping physicians and patients get to the right diagnosis, hopefully quicker, sooner than later. And I know that your company is helping do that. So tell us a little bit about bond triage and some of the cool technology that you're using. And we talked a little bit about AI earlier. So let's talk about how you're using AI to help this diagnostic journey for patients and again, assisting doctors do the same.
Okay. Along with my co-founder, Dr. Rob Cowan, who's a professor at Stanford University and up near San Francisco, over 10 years ago, we said, there's a big problem in headache. And at that time, we had 300 board certified headache specialists and 50 million people with migraine. And they can't get to us. So what do? They go to the general physician. And the general physician, up until the last few years, like myself even, had 1 hour about headache in 4 years of medical school.
Oh, wow.
And it hasn't gotten better in most medical schools or internships or residencies. And even in a good neurology residency, unless they happen to have a headache center at that place, they don't give them very much information about headache
Really?
because neurologists think headache, eh, everybody has headaches. It's not as interesting as multiple sclerosis, as epilepsy, as Parkinson's disease. That has a lot of science behind it. Headache has a lot of science now, and they just don't care about it, and they don't go into it. But certain types of doctors going through their training like it, and they're fat like I was. I was fascinated by the fact that somebody like you, for instance, busy doing all these things, could tell me twice a month you're lying in bed throwing up for 2 days, and there's nothing that helps, and then you're all better again. What is that? What causes that? So way before you were born, way back in 1979, I said, I
Oh,
want to be a headache
doctor,
specialist.
doctor, you can be my new best friend because I was born way before 1979. So
Sorry, I made that mistake.
no,
I have to be cautious, you know.
I'll take it as a compliment. I'm a 1970s baby. In fact, my birthday's on Labor
Well,
Day.
you were only 9 years old at the time.
I know. Way back when, but thank you for the compliment. I'll take it.
Okay, you're welcome. So, but way back a long time ago, that was the situation. And we said, there's got to be a way that we could either teach doctors how to diagnose migraine better or do something with computers to make it better. So
Mhm.
by then, many people had computers. I'm not sure they had iPhones yet, but they had computers. And we didn't do this in 1979. That's when I started to be a headache specialist. We started doing this over 10 years ago when people did have iPhones and they did have Google phones and they did have computers, and just about everybody that was sophisticated and had money had them. And we said, let's use artificial intelligence to help us make diagnoses for patients. And he and I were pretty smart, but we didn't know much about artificial intelligence. So we hired a specialist in AI who was full time at USC in California, actually working with the Defense Department part time secret stuff. And, he was trained in AI. And we said to him, we want to design a diagnostic program that asks all the right questions and comes up with a series of diagnoses for headache. But we can't call it a diagnosis because we haven't physically examined the patient. So we'll call it a clinical impression, which is my impression after taking this history. Because as we talked about, migraine and other headaches are diagnosed by history, unless it's a more severe problem, in which case you really do need to examine the patient. So he said, I'd love to do that. And so we all had full-time jobs, and in our spare time, we designed a program which exists today, but it's infinitely better because we've been improving it time and time again. And unfortunately, we raised a lot of money and spent a lot of money. And luckily now we don't have to improve it too much because it really works. But unluckily, we haven't launched it yet because it costs a lot of money to launch it. But patients can go to our website, which is www.bonetriage, spelled BONTRIAGE.com. And on that website, they can find out more about us, but they could also click do the assessment, or it'll take them to the store that they want to go to get the app. Both of these are free right now. We may charge for them in the near future, but right now, if you get it, it'll be free and it'll probably remain free for you. And the one that we would talk about would be the first one, which is what we call the deep dive. It's a deep dive into your headache. And it's the one we could look at I think I sent you one for cluster headache so people could see what it's like and what kind of information that
Yep.
we collect. But
Doctor,
basically,
Doctor, if I could interrupt just a minute, why don't we go
sure,
ahead and I can share that. So for those of you who are
sure.
on video, I'm going to be sharing the screen here. Um,
Okay.
and for those who are just listening, we'll try to get as detailed as possible. So as you said, doctor, there's an assessment that patients can complete about their history with migraine. And
With any type of headache, any type.
okay. Okay. So any type of
It's
headache.
going to make the diagnosis depending on what they put in.
Understood. Okay. And then the result of that is this very concise, handy report that the patient can take to a physician. So whether it be a primary or a neurologist, is that right?
That's correct. They can even go to a headache specialist with it. And a headache specialist would more likely say, I don't need this because I'm a headache specialist. And oh, that's Dr. Rapoport's. I know that to be a good one. That's probably
Yeah.
what they would say. But I don't need it because they don't need it. This is for the patient and for general physicians or neurologists that don't specialize in headache,
Okay.
because many neurologists see mostly epilepsy or Parkinson's, but patients come in with headache and they don't have the time and sometimes even the expertise to take this careful a history. So the very beginning says, Dear healthcare provider, and it's just an explanation to the doctor that the patient takes this to of what this is. And if you go down a little bit further, it starts with personal information. And this one isn't on migraine, so I'll just read what some of it said. This patient is a 45-year-old right-handed male. He is 68 inches tall. His weight is 170 pounds, and his BMI is 28. What is the BMI? It's a calculation done on height and weight, which tells if you're obese or too thin or just right.
Mhm.
And in fact, 30 or more is obese, 10 or less is probably a little bit too thin. So you should be between 10 and 30. He's 28. So he's not obese, but he's a little on the heavier side. Why is that important? If you're obese and you have migraine, there's a good chance you'll get worse if you continue to gain weight and possibly better if you lose weight. And I'll simply say, up until about 2 years ago, the hardest thing I ever did, other than trying to get someone from stopping smoking, was trying to lose weight.
Mhm.
Because no matter what you say to a patient and no matter how well intentioned they are, it's difficult. I know myself, it's difficult to lose weight.
Yes.
Today, we got this very magical shot that makes you lose weight. So
Yeah.
it's getting easier. But that's why we do the BMI on everyone.
Okay.
Next section is red flags. In this case, it says there are no red flags. Red flags might be in the history if they say something that makes us think they need further evaluation. So we don't say what we think it is. We just say to the doctor, there are some red flags, and we mention what they are. Like one might be every time I do strenuous exercise, I get a headache. That might mean there's something wrong in the brain. And every time I get a fever, I get a headache. That might be something, it might be nothing. So we do mention the red flags. History. These headaches came on at age 35, and he does not associate it with any particular event. Can you scroll down a little bit more?
Yeah. Yeah.
Characteristics. According to the patient, he has only one type of headache. We let the patients describe three different types of headache because many patients feel they have three totally different types of headache. It may turn out that I will say two of them are exactly the same, but they don't know that. It's on the same location each time. So right away, that's a little bit worrisome. He localizes his most severe headache to always on one side of the head. The part of the head most involved include around the left eye, and he characterizes it as a squeezing or pressure like. At its worst, the intensity of the pain is a 10 out of 10. At the mildest, it's 10. Typically, it's a 10. That sounds like cluster headache or the worst migraine possible. Untreated, this headache can last from 1 to 3 hours up to 12 hours, but typically 1 to 3 hours. That's not migraine, which must last more than 4 hours according to diagnostic criteria, international criteria. He confirms that without treatment, this headache typically lasts 3 hours or less. We've asked him 2 questions about this because if he says it's usually 10 hours, it might not be cluster. But if he says it's 3 hours or less and it's that severe before, and it's always in one place in the eye, I know it's cluster headache, but let's see what else he says. Medication usually does lessen the pain, reducing it to a 3. He has this headache 20 or times in the past. On average, he gets this 31 days a month, so he gets it every day. These headaches are frequent for days to weeks, then they disappear for weeks to months. That's cluster headache. Episodic cluster goes away for 6 months to a year. So we've asked that specific question, yes or no. Does it do this? Yes or no? So the next sentence is really important. During this headache, he describes the following signs and symptoms: drooping eyelid on one side, tearing of the eye, and redness in one eye. He does not list nausea, vomiting, phonophobia among the symptoms. This happened after head trauma. Laura, you know what this diagnosis is, since you remembered half of the things I said. This is cluster headache. It can't be migraine. It's not tension type headache. So go to the very bottom. We'll skip over all of this. We asked them about sleep. We asked them about exercise. We asked them about the timing. Let's just look at the timing. The patients are worse during the spring and fall. He notices worst headaches in the evening when he flies, meaning in a plane. His headaches can occur during the flight. Very typical. If you lower your oxygen tension by flying, airplanes are pressurized to 7,500 feet above sea level. If you're in an airplane for 3 to 4 hours and you have cluster headache, there's a good chance it's going to trigger a cluster. So I write a prescription for my patients that they're allowed to have oxygen during the flight.
Oh my. Okay.
And oxygen takes it away. Continuing on, orofacial pain, family history, none have been diagnosed with migraine. There's a history of stroke, past medical history, social history, previous testing. He had a CAT scan, which was normal. Behavioral, he denies feeling of rage. Over the past 3 months, his headaches have limited his ability to enjoy his life. Medications, there's that sumatriptan, which he takes, acetaminophen, which is Tylenol, preventive care, verapamil. That's what he's taking. This is before he came to me. So, somebody had him on the right treatment. And if you go all the way down, it says clinical impression. So what did the computer say? Episodic cluster headache, medication overuse headache, because some of the things he answered that he takes medication all the time when he's in this cluster headache cycle, possible episodic cluster headache, but probable episodic, but he definitely has episodic cluster, as the first one says, and headache attributed to trauma or injury to the head or neck. So if he takes this into any doctor who looks at this, we're not telling the doctor what the diagnosis is. We're saying, think about these things, because that's what our computer said. And our computer follows exactly the International Headache Society's diagnostic criteria.
Hmm.
And if the doctor doesn't say the patient has cluster headache and treats the patient for something else, and the patient doesn't get better, they should think about going to another doctor, really. I don't like to tell people to go to another doctor, but with this evidence, I mean, the patient will look at it and say, wow. So if I showed you the one for one of the ones for migraine, you'd see the same thing. If the patient has a one-sided severe headache with nausea and light sensitivity that goes on for 24 hours, and then 2 days later they're better, that's migraine.
Yeah. Yeah. Well, what a
So
wonderful tool for patients to be able to stop and think through their migraine history to help with communicating these symptoms to a physician, because we could talk for a long time about the white coat syndrome, as they say, and how patients get very nervous in an exam room with the physician, and they know somewhere in the back of their minds they're thinking, I have to hurry up because I know doctors only get so much time, and how do I get through my whole history, and I might forget something, and 9 times out of 10, you do forget something, and you walk out the door and you say, "Oh, I should have told the doctor this part of my history." So what a comprehensive tool to make sure patients don't forget anything, but also help physicians in the exam room with just time management, as well.
yeah, and if the doctor doesn't have time to read that very little writing that we saw in there, he could look right, though she could look right down at the bottom under the clinical impression. And, if the doctor says, no, it's not that, that's fine. And then explain to the patient why it's not that. And by the way, whatever you put into the computer uses to make a diagnosis. So if you don't answer the question accurately that's in front of you and you make up the story that, you think is important, you might not get the right answer. So you shouldn't try to second guess. And we've gone through it very carefully. I think you know what UI and UX is. We've gone over the UI and the UX multiple times with professionals. So when you go online with this, there's one question, it's easy to read, pretty easy to answer. And if you are unhappy with it or you can't answer it, there are many places where you could leave a note. But I must admit, it's better to have the patient in front of you, because if they weren't clear about it, they'd say, well, I don't understand what you mean by that. And then you'd phrase it differently. You don't have that option when you're in front of a computer
Yeah.
screen. I know
Yeah.
myself. I get very frustrated with trying to answer, something on the computer when it's not clear.
Exactly.
But
And
anyway, I
you
think
were
people would really benefit from this.
yeah, doctor, you were referring to the user interface and the user experience. Is that what you were talking about?
Exactly,
You were using some
exactly.
techie lingo, but
Very
speaking
techie
of
stuff, which I've learned working on this. And by the way, we have very good patients. My favorite patient to look at this periodically with us is a physician herself. And she tells me exactly what I want to know, good and bad. This isn't as clear as it should be. This is wonderful. Why don't you add this? Whatever. And we talk to her at great lengths, and she's very free with her time. And we offer to pay her, but she usually won't accept the money. And that's how we improve this. And I got to admit that everybody that knows, that has headaches, that looks at this, loves it. Anytime we show it to a consultant that doesn't have headaches, the very first thing they say is, this is too long.
Mm,
Of course it's long. I ask uh, 200 questions in my office. It takes me 45 minutes to take a history.
yep,
Do you know how long the average doctor, general physician, has with a patient, a new patient? You know how many minutes?
12 minutes.
8 to 12. 12 would be good. Can you ask 150 questions, 12 minutes, and talk to the patient and examine the patient and
Yep.
treat the patient? No.
Yeah.
So that's why this is helpful. I agree with you. You know, if everybody brought one of these in, some physicians would say, that's crap. You got it off the internet. If they saw the people that did it and saw our credentials, you know, they wouldn't say that.
Yep. Yep. And just briefly, doctor, before I know we have to wrap up because I know you need to move on to other things today. But speaking of technology, you also have an app that can be downloaded called Migraine Mentor, which is it a symptom tracker? Is that right?
So it does the same thing at the very beginning, but very briefly. So in about 15 to 20 questions, it will ask you about your headaches. It will ask you to name your headaches. And then what happens is every day it asks you to spend 3 minutes on the app, and it will ask you some trigger questions, even if you didn't have a headache. It'll ask you, did you have a headache? Yes or no. If you had a headache, it'll ask you to describe your headache briefly, and that's it. And at the end of a month, or certainly 2 months, you can go a little deeper into it. And that means you press the three dots next to each other. I always have problem with this. There are always three little dots next to each other.
Be
And
down.
when you
Yeah.
press the three dots, it'll say, do you want a report? And so you put in the date you want the report to start and end, and it will send the patient a report on the screen, or I think you can even send it by email. It'll send a report with the same little history, but much, much abbreviated, but it'll give you the trends that are happening. Are your headaches getting more frequent or less frequent? Are the intensity of your pain the same or better or staying the same? It'll even draw a picture of your headache and
Hmm.
put a number in the center, which you should do the very first time you have it. And then 2 months later, it'll superimpose the current picture with the original picture, and the number will change, and you'll see the shape of it, and you'll see if you're doing better or not. So
Wow.
when your doctor says, I want to try you on a preventive medicine, you should do this every day, and it will tell you and your doctor, are you doing better or not? And should that medicine either be raised or changed?
Wow. This is so exciting, doctor. I know we could talk a lot longer, but I know you need to be on your way. But for everyone listening, Dr. Alan Rapoport, thank you so much for being with me today. And his website is bonetriage.com. We'll put it in the show notes where you can find the assessment as well as direct you to the app. But it sounds like it's available for iPhone and Android. Is that correct?
And absolutely correct. And if you go to that website, you can just click on which one you want and it takes you right to it. And I will say two things. If you don't know French, it's hard to spell bone triage because a lot of people spell it BONE. It's
Mm,
not a bone. Bon means good in French,
yep.
and triage means figuring out where to put the patient.
Yeah.
In
I take
French.
my French, my high school and college French for granted, assuming people know.
I do too. That's what I had high school. So one of our wives actually came up with this wonderful name, and we like it, but it's a little complex for patients. But once you know how to spell it, just put that in and you'll come up with the website. You can read more about us, or you can just click on picking the assessment and click on going to the Migraine Mentor app.
Yeah, wonderful. Well, certainly no worse than any of those drug names out there either. So
Oh, yes. And by the way, when we talk to other doctors, we are required by the FDA and sometimes CME programs
Mhm.
to only mention the generic names, which are the tongue twisters. The
Yep.
doctors don't know anything but the brand names, so they don't know what I'm talking about. So I always mention the generic, and then I say the brand name. And sometimes I get yelled at, and I yell right back at them. I say, the doctor wants to know what I'm talking about.
Yep. Yep. All that marketing has done its job with the brand name, no doubt. Well,
Yes.
Dr. Rapoport, again, thank you so much for sharing all of this in-depth knowledge and all of your wisdom with our listeners today. Thank you so much for being with me.
Oh, you're very welcome. And I have to say, you got more out of me than almost any other interviewer ever. So I wish you were writing for the New York Times, so it would go to
Oh,
hundreds of thousands of people, but it probably goes to a lot of people. How many followers do you have?
well, we'll see how far I can get it. I'll have to leverage the people at the New York Times maybe to get more followers for
You,
me. But
you
yeah.
can tell them, if you speak to them, that I used to work for the New York Times right
Oh,
out
no
of
kidding.
college.
Oh my
That's
God.
another story we can talk about
Wow.
sometime.
That's another book, right? I have a feeling.
I almost became a reporter for the New York Times. I decided to go to medical school.
Oh boy. Well, it was an excellent choice, and your
Well,
patience
thank you.
and I are grateful for that. So thank you, Dr. Rappaport.
You're
Thank
very
you.
welcome.
Thank you for everyone. Thank you everyone for listening. I'm Laura Nozica, host of the Desperate for a Diagnosis podcast. Stay well, everyone, and keep pushing for answers.
Oh my goodness, that's a wrap on another compelling story. Thanks for listening to the Desperate for a Diagnosis podcast. If you would like more information about today's guests or to find out more about Laura, go to desperateforadiagnosis.com. If you enjoyed the show, please subscribe, rate, and review the podcast on Apple Podcasts, Spotify, YouTube, or wherever you get your podcasts. You can also follow show updates and healthcare news on the podcast's Facebook page. If you would like to be a guest on the show, or if you have any questions, advice, or suggestions for our guests, please email me at lauramarie@desperateforadiagnosis.com. Please note, I am not a medical professional, nor am I affiliated with any healthcare, pharmaceutical, or device company. I am an entrepreneur and an independent market researcher focused on helping healthcare organizations better understand the patient perspective. The podcast is not meant to offer medical advice, but to merely share the stories and perspectives of podcast guests.